Good evening, everyone. It's such a pleasure and honor for Mumbai CSI today for having organized this particular unique topic, which is a grand round. And the entire credit for this particular grand round goes to Milind Phadke, who is the brain behind this particular topic to be discussed today. Friends, we are really fortunate to have such luminaries today as far as this particular topic is concerned, which is rheumatic fever and rheumatic heart disease, the forgotten orphan. We have Dr. Krishna Kumar, who's the professor and head of Department of Pediatric Cardiology at AIMS Kochi, who's going to give a talk on this particular topic of rheumatic fever and rheumatic heart disease. And we have certain wonderful and very learned luminaries as far as the panelists are concerned. Dr. Vijay Raghavan, who is the Vice Chairman, Kerala Institute of Medical Sciences at Trivandrum. Dr. Satyavan Sharma, our own Satyavan Sir, who is the Honorary Consultant and Interventional Cardiologist at Mumbai Hospital. And we also have our own Dr. Pradeep Vaideshwar, who is going to be talking about the pediatric aspect of it and the pathological aspect of it. And he's the professor of Department of Pathology at the St. GS Medical College and KEM Hospital. So friends, without wasting much time, and just an insight is to how rheumatic fever and rheumatic heart disease has evolved since when we were students as PG students of cardiology, when we used to see so many cases of rheumatic heart disease, both active rheumatic heart disease as well as chronic heart disease. But things have changed over the last decade. And to discuss this particular thing, we have today Dr. Krishna Kumar to deliver the talk, and then we'll take it forward with the panel discussion and the questions from the audience also. So Dr. Krishna Kumar, please go ahead. You are muted. You are muted.
You are muted. Unmute yourself.
Can you see my slides, please?
Yes,
sorry.
Yeah, we are seeing, but
Okay.
you can put it on the slideshow.
Yeah, on the slideshow mode.
Yeah.
So thank you to the Cardiology Society chapter at Mumbai for this very significant opportunity. I don't generally say no to any request to talk about rheumatic heart disease because I feel that it is important to remember this disease because, although we get this perception that it is going away, especially in the vicinity of the populations that we serve, but the problem is still very significant. And there is an important need for us to be updated with all the developments that have happened. It's a very peculiar paradox. Globally, there is perhaps now a little more attention to rheumatic heart disease than ever before in terms of many leading health agencies like the World Heart Federation and many other organizations like the WHO. But with nationally and amongst the cardiology fraternity in this country, by and large, rheumatic heart disease is being mostly ignored. So I'll dwell into those reasons in this particular presentation, which will share my reflections. But I cannot start this presentation without the dedication. I have been introduced to rheumatic heart disease research entirely by Professor Tandon. The year was 1999, late 99 and 2000 when Sir handed over the Jai Vigyan mission project. And I was one of the nodal centers, and we had satellite centers. In fact, one of the satellite centers that I was asked to look after was KEM Mumbai. And we had Professor Karmarkar of the Department of Microbiology, who along with whom we did this survey in Mumbai also. And then, of course, we collected data from 10 million people, population, one of the largest global surveys on rheumatic heart disease. Much of the work was based on clinical identification because we could not scale up to doing echoes on everybody given the extraordinary magnitude of the project. But because of this project, I have really been able to, in fact, not only did he initiate my interest in rheumatic heart disease, but he kick-started research at Amrita Pediatric Cardiology because it enabled us to establish a research office and so many things came out of it. So I'm deeply indebted. At this point, I have to say that I'll start by the summary slide and I'll again end by this slide. And this is a paper that I just published in JAC in 2023, January. It's just come out and I'll definitely encourage you to read it. This diagram is from there. I think the few things that we should talk about where there has been real advances. One, the epidemiology of the disease is changed. And I think the importance of its relationship to the primary healthcare, quality of primary healthcare is something that we have to deeply understand. The natural history is also different from what you used to believe. I'll talk about that as well. There is some more insights into the etiopathogenesis, although it still remains a bit of a mystery. The Jones criteria have been revised completely, significantly, and are now very contextual. Then in the management, there is now a trend towards flexible penicillin prophylaxis, not insisting on injections in everybody, but identifying and avoiding a small population which is at risk. And then prevention is all about strengthening primary care. And one area that's not received attention is penicillin supply chains, which are a huge problem in India in particular. Policy-wise, there is a lot of action there. Again, the importance is to integrate it with primary healthcare. And the other very important aspect is universal health coverage for patients affected with RSD. It's not adequate. Patients continue to suffer, and it's an extremely expensive disease. So with this, I'll just touch upon some of these key developments. The definition really remains the same, and we all know what it is. It's acute inflammatory disease in response to group A beta hemolytic streptococcal throat infection. Now, there is a rider to this. There is an increasing amount of evidence that's being gathered from Australia that you may actually get it from skin infection as well. And there is, in Australia, it is firmly believed that you can actually get it from skin infection. That's not true for the other parts of the world, but there is a possibility that we can't exclude it. Now, the traditional paradigm is that rheumatic heart disease follows repeated attacks or may occur after a single attack of rheumatic fever. So this is the traditional paradigm, which is linear, which is what we are all used to. We say it's streptococcal infection, you have rheumatic fever, you have multiple episodes, then you have chronic rheumatic heart disease, then you have death. This linear model is no longer widely accepted. I think clearly it doesn't explain a lot of things. So now, firstly, pharyngitis is involved and impetigo or skin infection is also perhaps involved. And the episodes of rheumatic fever may or may not be identifiable. You can actually get direct rheumatic heart disease without identifiable episodes of rheumatic fever. And this is increasingly evident in multiple studies that we've been doing lately. And so this needs to be thought of very, very significantly, especially in highly endemic regions. There are two very important these are two important statements. Dr. Stollerman, who made this observation that despite the diffuse vascular involvement, one of the mysteries is the fact that disease has a remarkable tendency to heal, with the exception of heart valves. And Dr. Tandon actually put this is a beautiful article Dr. Tandon wrote in Nature Reviews in Medicine on pathogenesis. He gave his reflections. And what he says is that the valves are basically having a different structure, in that there are two layers of endothelium and there is a connective tissue core. So in reality, rheumatic fever is actually a manifestation of endothelitis, where there is diffuse involvement of the endothelium or inflammation of the endothelium. And in those areas where the structure is such that it cannot heal, it results in permanent damage. So that's the only tissue that results in damage. This is again a simplified hypothesis that we have damage to endothelium with adhesion molecules being expressed, T cells being activated, and then migration of the macrophages to the connective tissue core with inflammation, revascularization, and further damage to the endothelium. To a large extent, this is a very good hypothesis. It's been further refined, and again, this is available in my review that I just wrote for Jack. I will not go into too much details, but there are two theories now. One is, of course, molecular mimicry that we are all taught and familiar with, which has been refined to a degree that we now know the elements in the molecular mimicry theory. But there is also another theory that people have been discussing, and that is the neoantigen theory, where the antigen is modified and presented differently and results in a systemic inflammation. And the systemic inflammation is largely confined to the endothelium or linings, various linings. And so this is by and large the paradigm everybody is working under. And to some extent, a lot of the findings that we see are explained, but again, there are many areas still unexplained. To me, I think as cardiologists, it's really important that we understand the epidemiology and what has changed in the epidemiology. I think, and we also reflect a little bit on it, because we have this widespread perception that the disease is on the decline. We need to examine that perception a little more carefully. So I'm going to share some very interesting trends that have emerged in the last decade and a half, and I've been part of a lot of these studies. Now, this is what we think the RHD burden is largely constituted by. It's a pyramid. There's a big burden of subclinical disease. There is a slightly smaller burden of asymptomatic. Then it becomes manifest with disability, and then finally death. So this broad-based pyramid, so for every patient who develops manifest RHD, there are a few hundreds that may be having subclinical disease. And there are some very interesting and fascinating trends in this epidemiology. So what is subclinical RHD? We are increasingly aware that there is a clearly defined entity of clinically silent but echo positive. And it's genuinely clinically silent. It's not just that we've become poor at auscultation. There is, even the best of ears, you may not pick up these findings. So this seminal study, actually, this is the first two papers came out. The first paper in NEJM came out from Cambodia and Mozambique, where this entity was well characterized, suspected before that, but it was well characterized. And the paper became quite extensively quoted. And then it became apparent from all populations in other parts of the world, but that for every case that you see, there is a large burden of echo positive or subclinical rheumatic heart disease. This study is very important. Dr. Anita Saxena spearheaded this study in school children in All India Institute and the neighboring Vallabhgarh district. What she did was to look at rural schools, rural private, rural urban, and urban. And there was a very clear gradient of echo positive cases. So the urban schools had a 9.2, and proportionate to that were much fewer clinical cases. When you look at the rural government schools, that's where the burden was enormous of subclinical disease. She surveyed nearly 3,000 children, and the incidence per 1,000, the prevalence per 1,000 was nearly 25, which is really high, almost at par with some parts of Africa. I was involved in this study, in this very large effort made in Australia. And the reason I got involved is they needed somebody to read echoes quickly. And I remember having looked at nearly a few thousand, 5,000 echoes. And I submitted the research, the results completely in a blinded fashion. And what we found was very interesting again. When the whole result was analyzed, unblinded and analyzed, it was found that amongst the low risk populations in Australia, there was just no disease whatsoever, zero. Whereas the high risk Aborigines had a very high prevalence of definitive RHD. And we had these criteria that we had sort of come together with. So various categories of mitral regurgitation, mitral stenosis, aortic regurgitation, all this was present almost entirely with a 0.8% incidence prevalence, which is very high. But in the same geographic region, the low risk population had nothing, no disease. So much so this paper again looked at these two populations, and amongst the males and females, the indigenous populations had a supremely high incidence, whereas the non-indigenous populations were practically no disease. In fact, the disease was mostly amongst the older people who had contracted it many, many years ago. But amongst the younger ones, there was no disease whatsoever. And the incidence ratio was 68, which means for every case that you see in the low risk population, the high risk population had 70 cases. So these were Aborigines and who were remote from healthcare access. So the global burden, if you look at this paper, which came out in Nature Reviews, is entirely confined to these populations and to those regions where there is some concerns about the quality of primary healthcare. So I have made this picture by asking this question as to who is affected by RHD most. And clearly, there is this gradient. Most affected are rural poor and other marginalized populations like the tribals, like the Aborigines. Then the second category is urban poor. And this data, again, this is all based on real data. The urban poor data, the best study is from Pakistan, where Dr. Masood Sadiq looked at the poorer sections of Lahore population and found just the same number, 26 per thousand. But the difference was it was clinical. So the subclinical must have been much higher. Urban, middle class, and affluent. Now, over the years, we as cardiovascular tertiary care personnel, we've all gravitated or sort of reached where the affluent people live. We largely serve the affluent because we are all in metros. We all have to send our children to schools and colleges. So we've all moved where it's convenient to live. And we've moved away from those populations that are worst affected. So there's nobody looking at this population. As a result, if you look at the world, there is a 4 billion population, bottom billion, with per capita less than 1,500. They're largely forgotten. They're more marginalized, and we don't talk about them. We just don't consider them in our, it doesn't surface in our consciousness. So this is the point that I've been trying to make, is that before we start making the statement that rheumatic heart disease has disappeared, we have to be sure that we've looked at all places. And the peculiar thing is that these are places that are hardest to look at. I remember having worked with Chhattisgarh. My colleagues at All India Institute started this service in Chhattisgarh called the JSS, Jan Swasthya Seva. And they ran a clinic for many, many years, which had a tremendous burden of rheumatic heart disease. They used to send patients with mitral stenosis and advanced valvular heart disease to All India Institute by train, virtually, full coaches full of them reserved in the train compartments and sent to All India Institute for surgery. And that continued to happen while there was a perception. The actual admissions with rheumatic fever at All India Institute came down considerably. When I was a PG doing my MD, we used to have on an average 8 to 10 RF patients with, and all 5 features. Lots of patients had subcutaneous nodules, etc., etc. That just disappeared. I mean, you don't see that anymore. You do see rheumatic heart disease, but you don't see rheumatic fever in those numbers. So that is something that is perhaps relating to the changing profiles, how the marginalized are truly marginalized. So in those trends, I wanted to just share with you. This is a paper that I have co-authored where death trends have declined. There's no doubt about it. The number of people dying from RHD has declined between 2 decades, and it's come down further in the most recent global burden of disease study. But still, the absolute numbers are staggering. And the largest numbers are from South Asia, not from Africa. It's from within the subcontinent. And the important thing to recognize is that if you look at this trend of rheumatic heart disease in the affluent countries, like this is from Denmark and from United States, 2 countries that had trends recorded. And what we found was deaths per 1,000 as well as number of cases per 1,000 came down, but the decline had already started before the year penicillin was introduced. This is 1940. And rheumatic heart disease actually started to decline. Of course, it was accelerated by introduction of penicillin. Similarly, here as well, a more dramatic decline in the number of cases of RHD had already happened well before penicillin was introduced. It's very interesting because you find the similar trends in other diseases. You look at tuberculosis. Tuberculosis declined well before chemotherapy was introduced, well before BCG was introduced. If you look at measles, measles declined to a very minuscule level in the United Kingdom before immunizations began. So these diseases are all similar, and they're related to something more fundamental in the society. My friend, Dr. Negi, is very interesting. He's a very insightful researcher. He is the chief of cardiology at Indira Gandhi Hospital in Shimla. He's retired only recently. He did 2 identical surveys, 1990 to 91 and 2007 to 8. And I can take some credit because I pushed him into doing this survey and comparing and publishing this data. So as Himachal is a remarkable state because penetration of primary healthcare. It has the least privatized health system of all the states in the country. And you look at those indices as the infant mortality came down, as the per capita income nearly tripled or more than tripled, as literacy went up, as without real change in fact, population density went up, and number of people living per household or dwelling also was remaining the same. Yet during this period, rheumatic fever just crashed. The rheumatic heart disease prevalence, rheumatic heart disease, urban, rural, all populations came down. And this is very interesting because this is reflective of what I think is just good primary healthcare. This is one of the reasons why the disease has just disappeared from Kerala. We have a tremendous crusader in Kerala, Dr. Abdul Qadir, who really tries to track every single patient of rheumatic fever. And the numbers are in very small numbers. In the last year, around 20 cases rheumatic fever, all of state of Kerala. And in 2023, the first case of rheumatic fever was what I have reported from Lakshadweep. Actually, it's not Kerala. So the disease has really disappeared from those parts of the country with good primary care. And this is a very interesting study. This was the impact of breakup of Soviet Union. So the red arrows when Soviet Union broke apart, and the Central Asian republics, when the Soviet Union fell apart, things were beautiful as far as the trends of rheumatic fever was concerned. But after that, the primary care just went to pieces, and rheumatic fever surfaced and rose again. This is a very obscure paper, and not many people. It's difficult to find this in mainstream literature, but you realize the essence of this paper is that it's so intimately related to primary care. So my submission is that rheumatic fever, like many other diseases, go away as healthcare improves. We may take credit for it. We may say, I brought in penicillin, we started immunization, but reality is they go away on its own. So lots of determinants, I think the whole landscape of rheumatic heart disease determinants is very complex. There are numerous socioeconomic determinants, household, crowding. Crowding isn't such a big factor as everybody thinks it is. Exposure, the threshold for giving antibiotics after sore throat, which can abort epidemics of streptococcal infection. So many other factors, health literacy, etc., etc. But the bottom line is where your health indices are good, where primary care is good, the disease goes away, period. And that's happened in the West. It's happened in Cuba. It's happened in Sri Lanka. It's happened in Kerala. It will happen everywhere. You have good primary care, the disease goes away. To be honest, cardiologists have a very small role. What really matters is the quality of primary care. So having said that, it's important, therefore, to now revisit the diagnostic criteria, because until now, the diagnostic criteria was universal, the same for where you were, whether you were in a high prevalence region or a low prevalence region. And that was a mistake. So a group of people got together and the revised criteria, now we have two populations, clearly. So what is common to all populations are the usual criteria, that is 2 major, 1 major plus 2 minor, and slightly different for recurrent attacks, where you can also have 3 minor criteria for recurrent episodes, and the essential criteria remains the same. What's really changed is the definition of low risk and high risk population. It's a bit arbitrary. So if you have a rheumatic fever incidence of less than 2 per 1,000 and a prevalence of less than 1 per 1,000, which is where Kerala is, where Goa is, where perhaps Himachal is today, where many parts of Maharashtra are, they would classify as low risk. But if you're looking at Chhattisgarh, Bihar, parts of Orissa, you may end up with high risk populations there. So you need to kind of know where a reasonable idea of what kind of population you're serving before you apply the criteria. And you have liberal criteria for high risk regions and strict criteria for low risk, which is understandable. So accordingly, the criteria have become a little more liberal. You can actually have just polyarthritis, and that classifies as a major criterion, which is different from all it was so far. Whereas with low risk population, we have a different set of criteria. So now, again, the thresholds for fever, the thresholds for ESR, all are somewhat different. And again, I have to tell you, this is all a little arbitrary. It's still a bunch of people who sat around a table and made up this criteria, but the idea really is to give it a context. The other important set of criteria that came out is the World Heart Federation guidelines for echocardiographic diagnosis, and this gets applied to subclinical carditis. It's a consensus criteria that I was a part of, along with Dr. Anita Saxena as well. And we have this definite borderline rheumatic heart disease, which I'm not going to go into the complexity, but it's very useful when you actually use this for field surveys. And this is getting revised as we speak, and we will have a revised version. There are some somewhat subjective criteria. The thickness of mitral valve is a little subjective. The thickening of cords is a little subjective. But altogether, it actually works very well in identifying rheumatic heart disease. So this is an example of a normal valve, and this is an example of a thickened valve tip. And there are different thresholds at different ages. And this is all being applied quite extensively. This paper was published in Nature. Nature Reviews of Cardiology, and we're going to get a follow-through paper very soon in the next 6 months to a year. The Doppler criteria were also used. The jet length use was taken. Again, this is all consensus-based, not based so much on hard evidence, but what made sense to a lot of people. So based on all this, you have a very wide variety of nomenclature that has appeared. You have, based on clinical exam, you have clinical carditis, which is all of us are familiar with, when you can actually auscultate MR or MR and AR and confirm that by echocardiography. Clinical rheumatic heart disease, where the diseases are detectable clinically. But then you have echo criteria, which is subclinical carditis, where you have clearly a normal physical examination. And that's an entity we cannot refute anymore. The word latent is used for both subclinical as well as missed. And this is mainly for field surveys in Africa, where a lot of RHD is actually there. It's audible, it's auscultable, but not picked up so far. And then you have borderline and definitive. So this is something which is only partial fulfillment of the diagnostic criteria, and definitive is when there is all the criteria are met. So this is all the terminology that's emerging from rheumatic heart disease, again, from my JACC article that I published recently. The important thing about latent rheumatic heart disease is that it's been shown now through this extremely important study that Dr. Andrea Beaton just published in NEJM in 2022, the GOAL trial, where she showed that she randomized patients with subclinical rheumatic heart disease. Actually, the word was latent rheumatic heart disease. She randomized patients with latent rheumatic heart disease into penicillin prophylaxis and no penicillin prophylaxis. And clearly, a very beautifully conducted study and showed that there was disease progression, proportion of patients with progression amongst those who did not receive prophylaxis was substantially higher than those who received prophylaxis. And the risk difference was quite substantial. The question is, of the 400 patients, there was progression in 33. So clearly, this entity of latent rheumatic heart disease and subclinical is real. But the practical challenge is in giving penicillin to such large numbers of people in vulnerable populations. So these are all interesting research questions and the research pursuits. But to my mind, the solution for rheumatic heart disease is just very simple. Improve your primary health care and advocate for it. If you do that, the disease is going to go away. No matter what you do with everything else and what success you may claim from your interventions, the truth of the matter is that this disease goes away on its own if you can improve primary health care. So let's come back to what I was saying earlier. The epidemiology, again, it has changed, and it's important to recognize that the disease has not disappeared, but probably has gone away from our collective consciousness. And if we start looking for it, we'll find it. The disease it's no longer necessary for you to have episodes of clearly identifiable rheumatic fever to get RHD. In endemic areas, there is subclinical disease that progresses to RHD. Skin infections may be important. The Jones criteria is now context specific, whether you're in high risk or low risk population, and the criteria are liberal for high risk populations and strict for low risk populations. Subclinical criteria, carditis is now included in the Jones criteria. It's very important to recognize that. It's important to understand that when you manage these patients, it's very essential to pay attention to the whole life course of the disease. So giving prophylaxis becomes extremely important. And now there is this trend towards trying to give prophylaxis even for subclinical disease, with practical challenges exist, of course. The one thing that I didn't mention is that now the WHO is coming to make this recommendation. Those with severe rheumatic heart disease who have the highest incidence of death after penicillin injections, particularly probably from vasovagal-like reactions, not actually anaphylaxis, they can be given oral penicillin instead of giving them injectable penicillin. But if you give injectable penicillin to run-of-the-mill rheumatic heart disease, it's quite safe. There is very little being done to improve access to catheter intervention and surgery for these patients, even within this country, even amongst various schemes that exist. We don't have enough advocates for the disease, and that's something that we need to think about. Talking about advocacy, we need to advocate strengthening of primary care. Nothing is more important for disease prevention than that, because where there is good primary care, the disease is gone. Penicillin chains, supply chains is going to be something that's going to be beyond our control, because the industry is not going to manufacture this drug because it's no longer profitable, or even worry about its supply chain. So that is something that we have to seriously worry about. Then, of course, policy is very important to integrate rheumatic heart disease management into current programs of universal health coverage, Ayushman Bharat, and all the other schemes that have come. They're expensive to take care of, but somebody should advocate for that. So with that, I'll say thank you and just give you a little invitation for a program that we're planning in the first week of April. Thank you.
Thank you. Thank you, Dr. Krishna Kumar. That was wonderful talk, giving us an insight into what is the present status of rheumatic fever and rheumatic heart disease is concerned. I think before we discuss as far as the panel is concerned, I would request our panelist, expert panelist, Dr. Vijay Raghavan, to say whatever you want to as far as what Dr. Krishna Kumar has said. Yeah, Dr. Vijay Raghavan?
Can you hear me?
Yes, we can hear you. Yeah.
I have great respect for Dr. Krishna Kumar, especially because his last word was, improve your primary care. You may make the rheumatic fever vanish. But I'm a great disbeliever in many thoughts which are said to be scientific but not scientific. Fewer than 0.3% of people with a sore throat also get rheumatic fever. Fewer than 0.3%. And the main center of discussion of Professor Krishna Kumar was on subclinical rheumatic arthritis. Subclinical rheumatic arthritis. Where do you fix up this group of streptococci and acute rheumatic fever? I agree, rheumatic fever is a reality. I agree, rheumatic heart disease or a similar thing is a reality. But where do you connect these two? I still feel that there's a lot of gap between these two. There's a lot of presumptions and assumptions which connects these two to finally say that we are dealing with acute rheumatic heart disease or chronic rheumatic heart disease. That's where the complexity lies. We have to have scientific definitions. Not all group of streptococci produce rheumatic fever, only in rheumatogenic strains, that only in susceptible individuals. These are all presumptions and assumptions, not scientifically defined. So that's where the gap is. That's where the gap is. But in practical reality, I 100% agree with Krishna Kumar. Improve your primary care. You will make the rheumatic fever and rheumatic heart disease vanish from your community. And Kerala is an classical example. Classical example. This is what I have to say about current understanding. Don't be a blind believer of what is written, but question everything. Have we proved the connection between rheumatic streptococci and acute rheumatic arthritis? I would say no. Have you proved the connection between a rheumatic fever at the 7th year and a mild stenosis at the 25th year? We have very little connection. You say that ash of bodies, but what's the percentage of ash of bodies you find in patients with mitral valvotomy and have LA appendage biopsy? Not very high. Not very high. This is the basic fundamental aspect of acute rheumatic fever and group of streptococci, which I feel needs a lot more of explanation, not in our generation of microbiologists. Probably another generation may have to come in. It's like pernicious anemia. People thought it was a leukemia. They found that it is just a abnormality in nutrition. So there is some missing link between these two phenomena, rheumatic fever and group of streptococci, and connecting these two, we do not have strong scientific evidence. I have great respect for Krishna Kumar, but still, Krishna Kumar's final conclusion was absolutely correct, but still, I just find it difficult to connect these two to teach a group of undergraduate students.
Can I respond or? Hello?
Yes, sir. Please, sir. Please go ahead.
So I get your point that there are gaps between and I didn't probably make a strong claim that the relationship was clearly established. However, I trained at Boston Children's, and Dr. Don Filer, just asked me to, I was asked to write a chapter for the next edition of NADES Pediatric Cardiology. And I looked at the previous edition written by Dr. Filer, and he gave 6 reasons why. And Dr. Filer grew up in the era when rheumatic heart disease was beautifully characterized by the house by the workers at Boston. And Dr. Tandon was influenced by that as well. So there were 6 clear reasons why streptococcus was linked to rheumatic heart disease. And those were times when rheumatic fever was so discrete, so identifiable. It was having a different behavior at that time. I agree that something has changed. But at that time, there was very little doubt in the association. And then the doubt and the conclusions were all based on clinical data and epidemiology, and they were reasonably robust. And what was done was that firstly, the elevation of ASO titers that was identified, and the association, the temporal association between sore throat and occurrence of rheumatic fever in the era where antibiotics were not widely available. So there was this very clear association possible in most patients. The fact that penicillin was so effective in preventing recurrences, even today, even in latent, it is preventing. So there is clearly an infective component. Whether it's, you can challenge the organism, perhaps we don't know enough about it. So there were a couple of other criteria that were not as stringent, but again pointed towards the streptococcal basis for rheumatic fever. What is clearly not known is the manner in which this whole thing is happening. And the disease has changed for sure. You don't have these discrete episodes of rheumatic fever. Something has changed in the biology of streptococcus, perhaps we don't know. The other important piece that has never been found is this basis of rheumatogenicity. Nobody knows what that is. Nobody knows why some streptococcus is actually responsible. So there is a tremendous amount of literature, enough to the point that we are almost at the threshold of a vaccine as well. But still, I concede that there are lots of gaps, but I will not question the association between streptococcus and rheumatic heart disease.
Well, Krishna, that was very interesting as far as the subclinical presentation is concerned. So now we'll ask Dr. Sharma to give his comments as far as the talk was concerned about rheumatic fever. Yeah, Dr. Sharma.
Am I audible?
Yeah.
Of course, as usual, KK was brilliant, and he has contributed so much in this topic. I just want to make 1 or 2 comments, and in fact, these comments are for inviting further discussion. First is, about, when for years and years we thought that in acute rheumatic fever there is pancarditis. Now, as the literature progressed, we started denying that there is no myocarditis, and what we are having during acute rheumatic fever is pericarditis and valvulitis. However, in the earlier years when we used to see a lot of acute rheumatic fever and there were patients who had died with fulminant acute rheumatic fever, I had seen specimens with Dr. Kenray at KEM, and we used to see that in these specimens there used to be evidence of myocardial involvement. Even Ashok's bodies used to be grown from myocardium. And also, if I recollect correctly, there was a case reported from KEM 2 years back or so, where there was a lot of myocardial involvement in a patient during acute rheumatic fever. So in fact, I'd like to know from KK, what are the recent thoughts about the myocardial involvement in acute rheumatic fever? Is there an involvement of myocardium, or there is no involvement of myocardium? And also I'll put one more comment and then...
Lately, it's a very controversial and important area, sir. Dr. Tandon, sorry, go on, sir.
No, okay, you can finish this. No.
Yeah, KK, you're breaking, but you can. I think we have lost the connection with Krishna Kumar. Yeah, okay.
You can, yeah. So sorry, I just lost my internet for a second. So the point of myocardial involvement, there are two aspects to it. One is pathological involvement versus clinical or echocardiographic evidence of ventricular dysfunction that is attributable to reduced myocardial contractility. Pathologically, yes, there is Aschoff bodies. You might find inflammatory cells in the myocardial area. But as far as as far as we know or understand, there is no hard evidence of rheumatic fever resulting in reduced contractility of the kind that you see in myocarditis. Almost everything that happens can be explained on basis of valvular pathology. This is the widely accepted hypothesis. Dr. Tandon was very particular about it based on his vast experience and whatever he had studied. And I tend to agree with him that perhaps you do get pathologic involvement of the myocardium, but you won't get myocardial dysfunction from rheumatic inflammation.
Question, Dr. Sharma?
Yeah.
You were to ask him, yeah.
Yeah. Again, KK, just about, that why has acute rheumatic fever reduced in our country? And here I'm actually quoting Dr. Tandon. I've heard many of his lectures, and he used to say whether it is actually really an improved primary care or whether it has been the indiscriminate use of antibiotics in our country which has reduced the acute rheumatic fever. So you think that streptococcal sore throats are treated by antibiotics without knowing what is happening, and that has led to the reduction?
I think that's a very big contributor, sir, because if you know, the older texts used to say that when you have endemic streptococcal infection, the incidence of rheumatic fever is 0.3. Whereas if you have epidemic streptococcal infections, which is typical what you see in military barracks and elsewhere, the incidence is substantially higher, nearly 3. So clearly, by giving antibiotics, you abort these epidemics. And that is essentially why, whether it's primary care or indiscriminate use of antibiotics, I think perhaps both are responsible, but a good country that you should go look at. We've got some beautiful case studies from the country of Cuba. In fact, there are 3, Cuba and Costa Rica. So Cuba, what they have is just a masterful primary healthcare system, one of the best primary healthcare systems in the world, not manned by doctors, but by healthcare workers who have very good protocols for various diseases. Together with that, they have excellent education. So they don't overuse antibiotics, but they showed a remarkable decline in rheumatic fever. So that example is very much there. On the other hand, Costa Rica adopted a strategy of very low threshold for antibiotic usage in sore throat and eliminated rheumatic fever there also. So both these methods have been tried. And in India, I think it's very difficult to figure out what it is, but Kerala is still a very good example. Sri Lanka is also a very good example where antibiotics are not overused, but you have a situation where the disease is gone, almost gone.
Yeah. Dr. Sharma, you want to make any more comments?
Actually, one more comment, and then we can. KK, actually, of course, it's very widely written in the literature that skin infections can also lead to acute rheumatic fever. But many of us who have seen a large number of acute rheumatic fever in the earlier years, either we completely missed it, but we never saw in patients who are having acute rheumatic fever any skin infection. Of course, as you mentioned, this has been reported more from Aboriginal population in Australia. But is there any sort of any cases which you have seen or have been documented in our country?
No, sir, I haven't. And in fact, we used to have lots of these debates, but I don't think we have been able to link the two in India. It's been mostly our belief is sore throat. We haven't seen a clear association between impetigo and rheumatic fever.
Okay. Okay. Dr. Sharma, you have finished with your comments? Or
Yeah, I think
yeah.
let's be
Krishna, in
involved.
the same context, what Dr. Sharma had asked you, when we talked about streptococcal throat infection, we used to look for fever, we used to look for exudative pharyngitis and cervical lymphadenopathy. But now, is there an evolutionary change as far as the manifestation, or is it because of the early antibiotic treatment which you are giving, as far as beta streptococcal infection is concerned?
Just repeat that question, sir. I missed you for a second.
No, I'm talking about when we used to have conventional teaching as far as the beta streptococcal sore throat was concerned. We had fever, we had exudative pharyngitis, and we had posterior cervical lymphadenopathy. But now we don't see any of these situations occurring in the patients who have got sore throat. Is it because of the evolutionary change, or is it because of the early antibiotic therapy?
I don't have an answer for sure. I mean, antibiotic is very likely, but there are some good
I want to tell you that there's a global study that showed that if you use the overall global prevalence of streptococcal disease is actually not declined, while rheumatic fever has declined quite considerably. So that's the global studies that have shown that. And
yeah.
So that's something which it's going to be very hard to be sure.
The impact of antibiotic usage or an actual change in biology of streptococcus.
Okay. I think we'll move on to the comments by Dr. Pradeep Vaideshwar. Pradeep, are you there with us?
Yeah. I am there.
Yeah.
So thank you very much for that excellent lecture. See, basically this rheumatic fever anyway is autoimmune. So there has to be some kind of genetic predisposition. And there are so many streptococcal, strains. Some chiefly involve the heart, some chiefly involve the kidney. So it is very difficult to predict that which particular strain is going to affect the heart or going to affect the kidney producing like glomerulonephritis. So definitely there is an underlying autoimmune basis because not all the people who get sore throat necessarily develop rheumatic fever. That is point number one. Then the point number two is I completely agree with Dr. Krishna Kumar when he says that there is progression without noticeable episodes of rheumatic fever. And in fact, when we looked at our autopsy series, we had a large number of cases where rheumatic fever was present in a patient who only had fever off and on for a few days. So I think that becomes, so we cannot say that the patient did not have rheumatic fever. The patient definitely begins with a rheumatic fever, but it is not clinically evident. And regarding myocarditis, I think recently we published a series on rheumatic fevers, and we found that many of the cases did not fulfill the Jones criteria at all. I think among the 60 odd cases, only 3 cases fulfilled the Jones criteria. And in all the cases, we did not have pericarditis, but we definitely had myocarditis with Aschoff body formation. And a peculiar feature of this myocarditis is it is an interstitial myocarditis, where the interstitium between groups of myofibers is infiltrated by cells. So it is not like viral myocarditis, where in between the myofibers, you have lymphocytes, and that is why it produces some kind of systolic dysfunction. And continuing in that vein, if you do certain cardiac injury markers, it is going to be less in rheumatic myocarditis as compared to viral myocarditis. And unfortunately, I don't agree with the endothelialitis pathogenetic mechanism at all, because it is said that the valve has very little collagen. But whenever there is inflammation, there is going to be an expansion of the valvular substance because all that blood supply is going to come from the mitral annulus. And what we have noted is that initially there is marked expansion of the posterior mitral valve leaflet, and then it sort of spreads to the anterior mitral leaflet. Because anterior mitral leaflet per se does not have the spongiosa except towards the basal aspect that way. And as far as Mumbai is concerned, and as far as our surgical specimens and autopsy specimens are concerned, we have still not seen any decrease in the amount of rheumatic heart disease at all.
Thank you, Pradeep. I think those are very, very interesting and inciting comments which he has made. Krishna, you would like to respond to that particular thing?
No, I think those are very great insights from a very
Insightful and respected pathologist. I think I agree with almost everything. I might have been misunderstood when I said that it is entirely endotheliitis. What I was saying is that there is inflammation targeted at the endothelial cells, injury targeted at the endothelial cells, but in the valve, the importance of neovascularization is very important. I completely agree with that. I somehow did not show enough in my slides on that, but the neovascularization process actually greatly increases the likelihood of
getting the valvular injury and the predilection for involvement of the PML as against AML because of the fact that PML is much more accessible to the annulus of the occupies much more of the annulus as compared to the AML. So I think those are all very beautiful points. I completely agree.
Yeah,
and
thank you.
somewhere I think we have missed that there might be some kind of a focus in the valve itself, which is not there in the rest of the interstitium of the myocardium or in the connective tissue of the pericardium. There has to be some target in the valve. Maybe it is those interstitial cells which may have a propensity to, continue sort of inflammation and invite more and more of fibroblast and hence the scarring.
Yeah.
Thank you.
Yeah, thank you, Pradeep. Wonderful comments. I think we can have an open discussion as far as the panelists are concerned. And I will put the first thing to Dr. Krishna Kumar. You said as far as the echo criteria is concerned, you talked about thickening of the mitral valve leaflets. I can understand that. But I'm a little confused as far as what do you mean by pathological MR? Is there some different criteria for pathological MR?
Yes. For MR to be qualifying as a genuine Doppler jet, we need to have some criteria fulfilled, which is the jet length. Earlier, we had this threshold of 2 centimeters just to try and avoid mislabeling of what was insignificant jets of MR. The envelope should be completed. In the sense, we should have at least one of 3 cycles that should have a complete envelope. The peak velocity should be less than 45. Or I think we had set a threshold about that. And the color jet should be visible in 2 views. Again, this is just a consensus. This is not science. It's just a consensus between 20 people who were invited from all over the world who agreed, yeah, this is minimum criteria for pathologic Doppler MR. There are these Doppler criteria and there are these morphologic criteria. And there is a lot of subjectivity in all of this, but when they all come together, I think they are basically what we intuitively know as rheumatic heart disease.
Yeah, excellent. One more question. Krishna, you spoke mainly as far as primary prevention is concerned. But is there any change as far as the secondary prophylaxis is concerned for people who have got rheumatic fever now? Is there any change or it remains the same?
No change. In fact, no change, except that nothing is as effective as 3-weekly penicillin. Nothing. Injections are the most effective way of preventing rheumatic fever, rheumatic recurrences of rheumatic fever, and progression of rheumatic heart disease.
Yeah, Milind, please go ahead.
Yeah. Thank you, KK sir, for a very insightful talk. And actually, as you rightly pointed out, most of us are sitting in tertiary institutes in metro cities, and we see a different population of rheumatic heart disease. And I also work in a public hospital. So the slice of rheumatic heart disease patients that we see, we face certain dilemmas. And one dilemma is diagnosing rheumatic carditis in a patient who already has established valvular heart disease. So we get these children between say 10 and 20 years of age or 8 and 20 years of age, and they come to us with heart failure like symptoms. And many of them are previously known to have established rheumatic heart disease. So it becomes very difficult to use some of the echo criteria and clinical criteria. And it's a genuine dilemma. So do we treat these patients with steroids or not? Is it just some other cause of fever, or is it really rheumatic carditis? So how would you practically give tips for making this kind of?
So I think I have clinical criteria, lab criteria. So if somebody with a recent worsening, and we have no other alternative explanation for the recent worsening, a clear worsening in the clinical condition, we should raise the possibility of reactivation, especially if somebody is not compliant with penicillin prophylaxis. Second point that I find is that invariably you find elevation in inflammatory markers, CRP and ESR, without them being elevated at all, particularly CRP, then you can question the likelihood of reactivation. So I tend to give that some respect. Of course, there are other subtle clues like disproportionate tachycardia that's disproportionate to the clinical condition may point towards rheumatic reactivation. But I go by these essential criteria. I agree that echo is useless, practically speaking. You can't tell by echo that actually this is rheumatic reactivation versus existing ongoing rheumatic heart disease.
And so, I mean, sometimes these patients can have fever, tachycardia due to some other infective cause, and they may deteriorate clinically because of that. So it becomes very difficult, especially treating such a patient with steroids.
I think you might have to wait for a few days in those situations till you are sure that it's not something else, and then give steroids. So that's the way I would approach it. So the most feared condition is endocarditis, but you can have some other intercurrent infection. And if you wait, and usually you have those 3 or 4 days before you are very sure, and the thing is that a routine run-of-the-mill fever does not worsen heart failure in the manner in which rheumatic carditis worsening does. That clearly, you can tell that somebody's heart failure is worsened if you spend some time with the patient, and you can actually understand that much of the worsening symptoms are attributable to heart failure, then you can get at the cause. But I agree, it will always remain a judgment call, and you have to exercise your fine clinical judgment sometimes. That's the way it is. I have a patient in the ward right now as we speak, where I've also been challenged, and so his CRP came down. He had actually recent rheumatic fever. The CRP came down and then went back up again, and I don't know whether it's because we stopped the steroids. So it's very tough in some individual situations.
Sir, in naive patients who we are diagnosing rheumatic carditis for the first time, how many echo criteria have? Because people are described observing rheumatic nodules on the leaflets on echo. So
those are non-specific. The rheumatic nodules on the leaflet, I think, is extremely subjective. Sometimes you just get a cord and cross section, and you think it's rheumatic nodule. So it's highly the beaded chain appearance. All those things are very, very non-specific. If you have pathologic MR, which you can't explain through any other reason, that should be the most important criteria. The combination of MR and AR virtually clinches the diagnosis. So I think if you have pathologic MR in somebody whom we can't explain otherwise, that should be enough to diagnose rheumatic carditis. The leaflet may be thickened, you may have flail leaflet, you may have relative prolapse, you may have excessive mobility, you can have all those things, or you may not have any of that.
Biomolecular and the serum investigations are concerned, would you give the same weightage for the ASO titers as against the CRP in these patients who have got acute rheumatic fever, suspected to be having acute rheumatic fever?
So the ASO and CRP have different roles. CRP is an indicator of inflammation. ASO is an indicator of previous streptococcal infection. and it is classified as an essential criteria. And it is something that you should have, even if you have, you have elevated ESR, you should also have evidence that there is streptococcal infection. And since we practically don't do throat swabs anymore, we are by and large dependent on demonstration of streptococcal infection through elevated ASO. There are two exceptions, we are all aware of that. That is, one is chorea that happens much later, or if there is ongoing chronic carditis, that is indolent carditis, then you can actually have such an extended course that the ASO has come down by then. But I think in a very large proportion of patients, ASO is positive. The tricky thing is to know what the threshold for your lab is, because each lab has a different threshold, because it depends on the kits that you've got, the norms that you've set in your lab. But clearly, if there is evidence of elevated titers, or if there is a rising titer, that is a sign of previous streptococcal infection. I know something that was challenged by Dr. Vijay Raghavan, but that's the way we've been pursuing it.
Yeah. Okay, Krishna, there is one question from the audience, and that is by Dr. Amit Singhvi. Is rheumatic carditis seen in adults now, or it's only in the adolescent children or children?
It's not now. It's since times immemorial. Rheumatic fever carditis has been described in adults also. The oldest patient has been as old as 40 years of age with existing rheumatic heart disease, not naive rheumatic fever. Naive rheumatic fever is rare after the age of 15, but not undescribed. It does happen, but recurrent carditis happens all throughout. You're at risk. Otherwise, why give penicillin? So you're at risk even until the age, at least until the age of 40, and perhaps even beyond, we don't know. But at least until the age of 40, you are at a risk of recurrence. So it can occur in adults, no doubt about it.
Dr.
One
Sharma?
more question,
Yeah.
which was asked by Dr. Dargat previously, was whether there is a genetic predisposition and how important it is in pathogenesis.
I think the genetic predisposition is perhaps a very weak influence. It's very small in the context of the environmental factors. They are far more overwhelming and dominant. If it was a strong genetic element there, then the disease wouldn't have gone away the way it has gone away. So it's just disappeared from large populations where it used to be extremely prevalent. So I think the genetic elements is perhaps very, very small. You have a slightly higher prevalence in concordant twins. And within families, the clustering can be explained by the environment more than by genetics. And there are multiple studies, but there is no consistent genetic marker. All kinds of things have been associated, but the associations are weak.
Dr. Sharma, you would like to make any comments, or you want to ask any
Actually,
pertinent questions?
I want
Yeah.
to raise another important question. When we come to the question of secondary prevention, in a person who is genuinely allergic to penicillin, what drug you will use, KK? Because the sulfadizine is the one which has been approved in the literature and it's been in many guidelines. But is it used, or what do you?
No, it's not. It's not used, and now we are essentially talking about erythromycin, which is what is being used in most populations. What's been recommended, and there are some variations in that same theme of using bi-weekly azithromycin also. And these are the drugs that are mostly used. It's erythromycin and azithromycin that is tried out. Sulfadizines are no longer available.
And what is
Vijay Raghavan? Dr. Vijay Raghavan, are you still there with us?
Very much, very much.
Yeah, you would like to make any comments or any post questions to Dr. Krishna?
Kishkumar has contributed so much to the knowledge of rheumatic fever and rheumatic heart disease at the global level. I appreciate very much the points he presented and feel that this particular session which the Bombay people have organized has made us aware of what is the current status of rheumatic fever and how we should approach it and how we should look at the future of rheumatic fever is. I agree, in states like Kerala, you may find 2 or 3 cases a year of acute rheumatic fever today. We had 5 to 7 patients in the 1970s when I was working as professor after DM. But that thing is totally disappeared. And I agree with Krishna Kumar. This is because of the improvement of primary care. The emphasis which Krishna Kumar gave it to primary care is very important and should be understood by everyone who is dealing in this field. Thank you, Krishna Kumar, for bringing in this concept.
Thank you. Dr. Sharma, sorry I interrupted you. You had something, some more comments to be made. Yeah.
No, actually, I was just continuing on the issue of the secondary prevention. One thing which is very commonly done in practice, and KK, I'd like to have your comments, is about the duration to which, up to a particular age cutoff, when you should stop the rheumatic prophylaxis. And what I see very often in practice is, I have a lot of patients who have undergone a balloon valvotomy, and my personal approach is to continue at least up to 40 or even sometimes indefinitely. Now the patient will go from here, and even many friends who are DM cardiology, they will say, no, there is no need now. You had a BMV, so now you stop your prophylaxis. So now what message you will like to give to a larger audience about a patient who has undergone a surgery or who has undergone a balloon mitral valvotomy, up to what age group we should continue the prophylaxis?
Sir, I completely agree with you. There is no basis to stop prophylaxis just because you have operated on the valve. So there is absolutely no question of stopping it. If you do valve surgery, valve replacement, or if you do balloon mitral valvotomy, you are duty bound to give penicillin prophylaxis. Now there is a growing initiative to try and limit it to till the age of 40. I think there are many people within the country. Dr. Manjuran is a very strong proponent that there is no major benefit in continuing beyond 40. That's the threshold people are using, and it may even come in guidelines sometime. Again, this is very difficult to get evidence to prove it, but I think it's reasonable because the likelihood of rheumatic fever recurrences become less after a certain age. But before that, if you have already got rheumatic carditis and rheumatic heart disease, you're actually at a greater risk of recurrences. So there is no question of stopping it. We've seen so many recurrences much later in life, in the 20s, in the 30s, that there's no question of stopping it.
Okay, there is one more question from Dr. Saxena from Vadodara. Would you recommend injectable or oral penicillin as far as prophylaxis is concerned? And
so very clear, sir, injectable is vastly superior. Oral has a very high failure rate. Oral is available as penicillin G and penicillin V. The penicillin G bioavailability is extremely poor, and unfortunately, that is the predominant form of penicillin available in this country today, pentids. K-pen or penicillin V is much better, but it is not manufactured in most parts of the country, except there is an attempt to actually revive it in Kerala. But by and large, it's not available. The efficacy of penicillin G is about 60%. Efficacy of penicillin V is about 80% in terms of prevention of prophylaxis. But when it comes to injectable penicillin, 3 weekly is something like 94%, and 4 weekly is 94%, and 3 weekly is 97 to 98%. No comparison between the various modalities. So injectable is the best way of doing it. And again, in a run-of-the-mill patient, the risk is not substantial.
And the second question by the same Dr. Saxena is, what are the specific changes as far as the new criteria of rheumatic heart disease is concerned? Are there any specific?
No, I think there are no specific changes. I think you are referring to echocardiographic criteria. Those are so that the first set of echo criteria we wrote together as a global group in 2012 and published, and I shared that WHF criteria. I have to say it was somewhat subjective, but it was subject to a very vigorous validation process. We went through thousands and thousands of echoes before we actually agreed upon criteria. So there was a tremendous consensus which came out of it. And then we recently worked on it and found that there are some deficiencies. So we're going to come up with a new set of criteria. One of the changes we expect in the new set of criteria, we're going to take out borderline disease. We're going to have either RHD yes or no. Borderline in between is not something that we're going to keep. We're going to say yes or no. And we're going to have criteria that are reproducible. And believe me, it is very useful to have these criteria because especially as people don't see rheumatic heart disease, they don't know what to diagnose. So it's important to give them some guideposts. So there are morphologic criteria and there are Doppler criteria. Morphologic criteria are for the mitral valve, thickening of the leaflet, thickening of the cords, which is subjective. Thickening of the leaflet is 3 millimeters for children and 5 millimeters for adults. Restriction of leaflet mobility or excessive leaflet mobility, either of them or both are criteria. So you have this classic hockey stick appearance of the AML, which is a basically restriction of the leaflet tips. Or if you have prolapse of one of the leaflets without in the context of being in a high endemic zone, then you have to consider that as a possible morphologic criteria. Similarly, you have morphologic criteria for aortic valve in forms of leaflet thickening, uprolled edges. And then there is Doppler criteria of pathologic AR, pathologic MR that we had discussed. So all this together, you need to have to be able to identify, label somebody as rheumatic heart disease. So the very strict and rigid criteria that we had put down together, and very useful when you do research and when you do field studies.
So Krishna, as far as the echo criteria, which you just mentioned, as far as prolapse of the mitral valve leaflets. Now, if you have a myxomatous degeneration of the valve and if you have a prolapsing leaflet with an MR, is it possible, or you have certain other criteria to harp on to say that this is going to be a rheumatic and not a myxomatous valve?
The thing that you see in a myxomatous valve is that you have pure excessive leaflet mobility. You don't have any restriction of mobility. Whereas with rheumatic heart disease, there is fibrosis, and that results in leaflet restriction of typically AML. You see that the PML also gets fixed, but AML will have this classic relative less mobility at the leaflet tip and good mobility at the belly, resulting in this classic hockey stick or dog leg appearance. So that, together with thickened cords, is also a very useful feature. And if there is prolapse of both the leaflets, obviously MVP will come in very closely in the differential diagnosis. At that point, you have to put it in clinical context, and you have to look at the patient as a whole. You need to put it in the context of whether the patient comes from a very high endemic region, where the prevalence is extremely high. Then your threshold for diagnosing MVP versus rheumatic, subclinical rheumatic may be different. I know that there are going to be gray areas and areas of overlap, but by and large, if you apply the WHF criteria, you arrive at a diagnosis which others agree upon.
Yeah, Milind, please go ahead.
So, one question regarding the diagnosis of carditis, like in so many other causes, does MRI play an important role, or can it have some role in your experience in rheumatic carditis?
Yeah, what plays the role? MRI? What did you say?
MRI. Cardiac MRI.
CMR.
Cardiac MRI, no, I think, no, it's too. See, the thing is that rheumatic pathology is entirely confined in and around the valves. And MRI is actually pretty poor for valves because the frame rates that you need are too low. And you get tremendous frame rates with echocardiography, which MRI can't compete with. So echo remains supreme when it comes to rheumatic heart disease.
Yeah, even for
So
myocardium, the involvement tends to be very patchy, very minimal. And I don't know whether, I think it will be a bit of an overkill. It can be a research study, and people can look at it from a research perspective, but for clinical purposes, it will be overkill.
Krishna, there is one interesting question. Any pathophysiological factors that protect the pulmonary valve from rheumatic heart disease?
Yes, I think so. I think it's the kind of pressure gradient across the valve, the pressure difference, the pressures that the valve deals with. And upstream, in pulmonary valve, the upstream pressures that is very, very low. Similarly, the typical tricuspid valve seldom gets involved unless there is right ventricular hypertension. In absence of right ventricular hypertension, tricuspid valve involvement is quite exceptional. So I think the hemodynamic factors are important in the progression of valve damage. Very, very important. If we didn't talk about in my talk, I should have mentioned it perhaps. They are very important in the progression of valve. The mitral valve is the most vulnerable. Aortic valve, after that, tricuspid valve, and finally, pulmonary valve is really, really rare.
Excellent. Pradeep Vaidishwar, are you there? You want to make any comments?
Yeah, see, the thing is that when we study both the tricuspid and pulmonary valve on histopathology, that has always shown us healed valvulitis to the extent of almost 85% for tricuspid valve and around 35 to 40% for pulmonary valve. So on microscopy, there is an element of valvulitis, but when we look at the valve on gross examination and hence functionally, there is absolutely no change.
Okay. So Anand, would you like to have any comments or you want to make any?
No, my only comment is what is the long-term implication and side effects of penicillin?
Nothing really that has been identified. Long-term
Absolutely safe. We've got millions and millions of people all over the world who've received it for so many years, and we don't know of any specific effect that is identified.
So, if erythromycin is the oral drug of choice, then why not make it as a standard of care instead of having the
No, I think
injection?
penicillin B is superior to erythromycin. Penicillin B has much better. So if you can't give injectable penicillin, then I think you should try and get K-pen. It's only a question of not being available, but it's much better than erythromycin in terms of side effect profile. It's so much
than erythromycin, and it's much less. It's much more easy on the stomach. Erythromycin can produce a lot of gastritis. So, no question, between the two, it's a preferable drug.
So Milind, you can take it over. Yeah.
So you said that in patients with established rheumatic heart disease, a slightly higher incidence of death following prophylactic penicillin injections has been found, and it is probably vasovagal in origin rather than strictly anaphylactic.
Yeah.
So
Yeah.
on a practical basis, do we reduce the frequency of injections, or is there some way?
Yes, I think based on these observations, if you have somebody with very severe disease, and the first thing is, of course, to try and fix that disease and get the valve disease taken care of. But while you're doing that and the patient is still due to receive penicillin, it's reasonable to switch to oral penicillin. Somebody with critical mitral stenosis, severe aortic regurgitation, in heart failure, these are patients who die after penicillin injection. If you look at all the deaths, if there's an audit on all deaths with penicillin injection, it's always people with severe established disease. So these are patients, it's completely reasonable to try. And there is a lot of, there are a couple of papers have come out on this, and this will be part of recommendations.
Once in a couple of years, we see this kind of mortality, and which is very.
Yes. And it has a devastating impact on rheumatic heart disease control. So I think it's very reasonable to make an exception. But the thing is that we need to get better oral penicillin. Penicillin B, it's very ironic. You can get it very easily in Nepal. Nepal makes oral penicillin B very much more than India. India, nobody's interested because the government has such a tight price control on penicillin that pharma industry finds it extremely unprofitable. And it's very interesting about penicillin. All the active pharmaceutical ingredient, the entire world's active pharmaceutical ingredient for penicillin comes from China. They take the ingredient and give it to companies that then use those ingredients to manufacture various forms of penicillin that we are using in the market. That process is actually far more expensive for the company than what they end up being allowed to charge for the penicillin. So they won't go. I think the government has been a bit thoughtless on this whole process. And we've not been able to advocate with the government in making sure that this is available. So this is just a breakdown of our healthcare systems that we see out here. It's a very universal problem in many developing countries, including India. And it's a real issue.
So Krishna, one more question. Is there any change as far as management strategy is concerned if you have recurrent rheumatic fever or relapsing fever?
Management regarding which management, sir?
I'm talking about the recurrence of rheumatic fever.
It doesn't change anything. Recurrence of rheumatic fever or a first episode, management of rheumatic fever remains the same. The criteria that you use for giving steroids, the duration of steroids, everything remains more or less the same.
Yeah, Milind?
And have a slightly lower threshold for steroids in patients with established heart disease, or it's not that?
I think the decision on using steroids is typically a very clinical and very individual one, where if you feel the patient is really worsening and you need to give rapid relief, we resort to steroids. If it's proven carditis, it's perfectly reasonable because you shorten the course of illness so much significantly. The patient feels better so quickly that it's well worth giving it for symptom relief. It doesn't change the natural history. We all know that, but it still can be very, very effective in making the patient comfortable quickly and eliminating heart failure symptoms. So I think using steroids at least when there is heart failure in the context of carditis is perfectly warranted.
In fact, we used to use steroids when there is evidence of pericarditis at that time. But of course, now we can use it when the severity is there. Yeah, Milind, you can take it forward now. Yeah, I think we have almost come to an end. Yeah.
Yeah, I mean, if there are no audience questions, probably, and if there are, I would just call for any final comments from the panelists, Dr. Vijay Raghavan sir, Dr. Satyavan Sharma sir.
Dr. Sharma, you would like to make any comments before we wind up? Yeah.
Just a very short comment, and of course, a question also for KK. KK, how often you have seen constriction developing in patient who has got severe acute rheumatic fever? Have you seen any patients? Because what we used to see in earlier years, sometimes when these patients used to go for surgery, the surgeons used to see a lot of pericardial thickening, and they used to have some problem in stripping the pericardium, but never any full-blown constriction.
I have never seen any constriction in the context of established rheumatic heart disease or people with recurrent carditis. The pericarditis completely heals.
Yeah. Any comment more from Dr. Sharma, please? Or Dr. Vijay Raghavan or Pradeep?
Thank you for organizing this meeting. It was a very good review.
Thank you. Pradeep, you want to make some final comments or?
No. Thank you.
No,
Thank
okay.
you very much.
Okay, Milind. Yeah, take over.
Yeah, so we are just coming to the conclusion of this meeting, and it has been highly informative, and I think the speaker and the panelists have really done great justice to this topic, and all the clinicians as well as students that you must have enjoyed. So I please call now upon Dr. Anand Rao to conclude and propose the vote of thanks.
Yeah, thanks, Milind. I think this was just wonderful. I would like to thank first our speaker, Dr. Krishna Kumar, masterly oration and answered everything so lucid and so specific in everything. Really, thank you so much. I would like to thank our distinguished panel, Dr. Vijay Raghavan, Dr. Satyavan Sharma, and Dr. Pradeep Vedeshwar for being there and conducting this program so well. Next, I would like to thank Dr. Milind. You are taking this up, and this is a great kind of thing, Grand Round Journal Club and so on. So really, congratulations to you for conducting this and taking all this pain. And from being the CSI Mumbai, I would like to thank our president, Dr. Ajit Desai, for being very supportive to hold these teaching programs, and all the executive committee members of the CSI who are always with us to support. And with their support, we are able to do all these things. Last but not least, I would like to thank our sponsors, Lupin, for agreeing to hold this program. And I thank one and all. Have a very good night.
Thank you. Thank you, Krishna Kumar. Thank you very much, Satyavanji.
Thank you.
Dr. Pradeep and Dr. Vijay Raghavan.
Thank you.
Thank you,
Good
Milind.
night.
Good night.
Thank you very much, everybody.
Good night.
Have a good night. Good night.
Thank you, sir. So